they come whenever there's a very high grade spondyloptosis. They they are very visible to you. They have a high lumbar lordosis, loss of sagittal balance, hamstrings are sparse. They slowly start walking with a simian gait, with your knees flexed, and that's when you they get into an unbalanced mode, and that's when they really need treatment. So already there is reduced area which has been already mentioned. L5 is trapezoidal, and it is the exiting L5 root which is right in front of you while you open this, and that is what needs to be protected and needs to be dissected out. And pelvic incidence, all these parameters have already been by Neeraj, and so these are very important parameters. So unless you balance the whole sagittal curve, probably in the long run, as they are all very young patients, have highly demanding patients, over a period of time they may deteriorate, or your implant may fail if you have done in situ fusion and not included the whole curve into the fusion mass. So you have to divide them into balance, although low balanced pelvis and an unbalanced pelvis. So high PT, low SS, that is an indication that this is going to be an unbalanced pelvis, and you need to work them. So reduction of high-grade spondylolisthesis improves cosmesis, corrects hip angle, improve kyphosis, restores sagittal balance. There are very high chances of neurodeficit, and in case you are doing an in situ fusion, even then, as I told you, the L5 root may be right in front of you. In case you don't dissect that out and you don't decompress that root, you might cause some deficit. So even on reduction, you need to. So conventional posterolateral fusion has its own problems. The graft is placed under tension. There is low fusion rate, elongation of fusion mass over a period of time, and failure does happen in such cases. So reduction gives us quality of fusion construct optimize, as we already discussed, and because there's a larger surface area where you get this fusion. And ultimate aim is to restore your balance, sagittal balance, and get your center of femoral heads right in line with the, this C7 S2 line. For high-grade prosthesis, it is very important that there is a meticulous exposure of L4. The whole key is to disconnect L5 and S1 completely. Unless you do that, you will not be able to get the reduction. Your screws may fail on table. So the entire disc is removed, flatten the dome of S1, disconnect L5 and S1 completely. Usually they are dysplastic, so you will have to look for the proper anatomic guidelines. You might miss certain things if you are not, because as I told you, they are all dysplastic. So complete disconnect is important. Then you put an L5 pedicle, which is easy. You're already done the laminectomy, so your pedicles are right in front of you. You have to look for them. Here, MIS may be a little difficult, but I'm sure with experts like Vishal, you might be able to still get an MIS into that, but otherwise you need to, because there's a lot of fibrocartilaginous tissue, and you need to really look for the pedicle entry points in these cases. What I personally do is I put S1 polyaxial screws, tighten the rods. Yesterday you must have seen Dr. Kshitij do the OC reduction. It works almost on the similar way. You fix your S1 screws, use reduction screws in L5, and then with your rod contoured, as you start pulling up, the reduction screws are not actually to pull it up, they are to distract. The rod stays within the reduction screw. So you just distract like railroad, you get it into distraction, stretch the whole column, so it starts slowly getting up once you have disconnected the L5 and S1 completely. So once you have done that, you tighten the reduction screws, then loosen the S1 screw, and then get the lordosis again. So that gives an excellent reduction in such cases. So that is how you can, this is one of the earlier cases where you used to use bean cages in such cases. Now we use P-lift or T-lift cages in these situations. So coming to spondyloptosis, it is a grade 5. The goal of treatment still remains to relieve the pain, neurological deficit, provide a long-term stabilization by solid fusion. So we can see the L5 is actually lying right in front of your S1. So any reduction maneuver is going to be very tough. Your screws may not last, and Indian bones are very soft as compared to Western bones, and your screws gives up, while you have already got from grade 4 to 3, 2, your screw hole may loosen up. So then we have to accept the in situ situation, and so the fusion mass is not very solid, and your sagittal balance is not restored. So over a period of time, there there is an adjacent segment disease and probably the failure of the implant also. So what I have taken off from the two-stage procedure of Dr. Gaines, which was the gold standard for such procedures, although I have little bit modified, where he gets L4, complete excision of L5, and then L4 on S1, flattening the dome. But still, you have the lumbar lordosis is not restored because it is the column is shortened. So we tried to get it little modified by doing a two-stage procedure, where on stage 1 we went anteriorly, either retroperitoneal or transperitoneal, with the help of the vascular surgeons, and did partial excision of the L5. If you can see here, this is the bifurcation. You can see the disc space there. This is the disc. This is the part of the body which is remaining. The rest has been removed, which is right in front of the S1 there. So you can feel the S1 traced with your periosteal elevators, and you have to ligate the mid-sacral vessels, and then you are right in front of that. So then you slowly lever it, and so that you loosen it up, so that once you go posteriorly, the two are completely disengaged. So then your posterior remains the same. You can see the roots there, and this is what is being done. So you remove the part of L5 below the trapezoidal part, flatten the dome, and then even with the position, once you have positioned them for stage 2, the reduction is almost visible there, and it's very easy to reduce it bone on bone. So this is what actually is planned. You can see a case there, and you can see L4, that is the reduction. So this is the pre-op, so you can see so this much bone is removed. So once you approach here, you just feel the sacral dome, this promontory here, remove the disc, and then start osteotomizing this part of the bone, and then free the jacket up. You can put your periosteal elevator or even your tail shaver here, and then just try to loosen it up a little bit, so that once you position them for the second stage, the reduction is almost very easy. So this is the post-op stage 1. You can see the part of the half of the body. So even just by positioning, the whole thing starts coming up. So this is the reduction. And that is 6 months. That is little bit of loosening of the reduction, but still it held, and you can see the bony mass here. That is 1 year. This is the patient, young boy. So that is that's it.